and the advance directive have to come together. You use the directive to have conversations through which you share your philosophy. Because an advance directive that's 10 years old can't really anticipate all the new medical things that have occurred in those 10 years. But your philosophy and your values should stick with that person to guide them to make decisions if there isn't an updated advance directive. Patients should also ensure that their physician has an opportunity for input. Studies show that 12% of patients with advance directives had physician input. Only 12%. They didn't talk to their doc. Now, part of that is maybe the doc wasn't able to listen very well about the desire to talk about it, but it's oftentimes seen as a legal document. They talked about it with their attorney as they prepared their will. So talk about it with your doc. And only about 70% of physicians whose patients had a directive were aware of it. I'm sorry, I flipped that around. Only about 60% of physicians whose patient had a directive I'm sorry. 60% of physicians whose patients had a directive knew about it. So not all your doctors know about it. So you need to tell them. I think nowadays we advise making copies for the doctor, for the hospital, for the family members that's going to accompany you to the hospital, for your attorney, for the times that your doctor loses them, that the hospital loses them. So you should make a lot of copies. I'm smiling a little bit about that, but be prepared for these things to get buried, particularly with the electronic medical records now. They may get scanned and stored nicely, but sometimes they don't make it to it. And in the paper records, they get buried deeper and deeper. So make sure that you have multiple copies and make sure your doctor has them and many of the family members have them as well. Any questions about preparing and implementing directives? So what happens if you don't have one? What happens if you don't have one? Well, if you don't have advance directives and you appointed a healthcare agent, that agent can make any and all decisions under any and all circumstances for you if you're unable to. So some people have done that. In fact, I've done that with my wife. I've said to my wife, I can't anticipate the future. I can't figure all these factors in for down the road, but I do want you to make decisions for me. So I've appointed her an agent, my healthcare agent, without a lot of directives because I don't want to tie her hands. I don't advise that for older patients where they have real concrete issues, real concrete problems. I don't have a lot of problems right now, so it's hard to anticipate what kinds of decisions she would be making. And so I said, well, I trust you, and so if I don't have a directive, I at least have an agent. If there's no agent, the law in Maryland provides for a surrogate to make decisions under 3 conditions. The surrogate can't make any and all decisions under any and all circumstance like an agent can. A surrogate can make decisions if there's a terminal condition, if there's an end-stage degenerative condition, such as end-stage dementia or Parkinson's disease. An end-stage has a legal definition as well, that they need to be dependent for their activities of daily living. And if the patient's in a persistent vegetative state. If any of those 3 conditions exist, and typically you need a couple of physicians to certify the presence of those conditions, a surrogate can make decisions that an agent could make. If those decisions, if those conditions aren't present, the surrogate's decision-making is limited to affirmative things. They can say yes to interventions, but they can't really say no to a wide range of interventions. So a surrogate in Maryland has standing to make some decisions under some circumstances. It's not as wide as the healthcare agent. So who's a surrogate? First is the spouse, second is the adult children, then the parent, then adult siblings, and then relatives or friends. So there's a hierarchy of surrogacy. And so you as a spouse would be first in line. If there's no spouse, then it's adult children, and then parents, and then down the line. Surrogates of equal rank have equal authority and standing. This creates problems. I see some knowing smiles. You must have children. Adult children all have equal standing. Every one of them. So this is why sometimes older parents will be sure to name an agent if they imagine their children having to make a unanimous decision. That's an important thing to remember. Surrogates of equal rank have equal authority and standing. As the Ethics Committee chairman for years, this was a very common problem, and the Ethics Committee often gets involved in these situations. And they're the most challenging ones to figure out what's the right thing to do. So the common conflict that we see is the out-of-town family member. And we have a name for it. It's the daughter from California syndrome. And it's understandable. Those that are at the bedside and there every day form a different understanding of the disease and its impact and the quality of life and the conversations that are natural from being there. But someone out of town who feels equally attached but less engaged to the day-to-day feels entitled to make decisions. And so they often come in and often create conflicts about what should be done when it was thought to be a settled matter. We as docs have had this happen. I've had it happen, and it's not a comfortable feeling because you have to start all over again in terms of bringing people on board and informing them and bringing them up to this point that half the family members are at. Advanced directives obviously help reduce such conflicts like this by, enabling there to be a unified message to all the parties that might be interested. Question?
Can you explain the difference between a surrogate and a power of attorney?
A power of attorney there is confusion about a power of attorney because when we talk about power of attorney, there can be two types. One is power of attorney over possessions, and we often have our attorneys draw up those kind of power of attorneys to execute business and property and possession issues. Then there's the power of attorney over person. The power of attorney over person is the healthcare agent. So that when you're working with the attorney, make sure you're drawing up papers that deal with both possessions and property and with person, with you and your medical condition. Does that answer the question? In Maryland, they tried to, in the law that was from the 90s, they tried to clarify that by saying not power of attorney for medical care decisions, but healthcare agent. And so that's the language that's preferred. It's clear, but there is that confusion then. Well, is the healthcare agent also a power of attorney? The answer is yes. So we're almost done. The EMS do not resuscitate order. This is on slide 16. If there is a decision not to have CPR, a separate document needs to be completed. Your advance directive, your healthcare agent, even if they were standing in front of the EMS crew, the ambulance crew, is not empowered by the state of Maryland to give an order to that ambulance crew. The only order that they will take is one that's executed on this EMS do not resuscitate form. It's standardized, it's easily recognizable, and imagine why they had to do this, and I understand why they did this, because the EMS crew has to take action promptly, and they have to have a doctor's order to act. And they can't stand there and review the patient's legal file to find the advance directive because time is passing. So the EMS form was devised in the 90s for families and patients to make this decision and to communicate it to the emergency response team. So if you have made the decision not to have CPR, then you need to ask Dr. Green to execute a DNR form that is on the approved format and language that is easily recognizable by the ambulance and emergency technicians. The current EMS form is on the website, and in your handout are some of the websites. The current EMS form allows you to have options as to when and what the EMS crew, the ambulance crew, will do. There's a comfort-only option, which means they'll administer oxygen and give you medications such as morphine for your comfort if this is in fact is your final moments. Or there's the option that you can have interventions up to the point